Today I'm going to be talking about BPPV. I'm actually going to go into a lot more detail with this PowerPoint than what's already in the CBTs. The CBTs is just kind of like, I feel like it's kind of memorization. If it's posterior, you do this, that. This one, we're going to go into detail of the whys and the hows so that you guys have a better understanding of what's happening, the anatomy, the pathophysiology and everything, because I feel like that helps me understand what I'm seeing and what I'm doing instead of just memorizing what to do for what situation. But this PowerPoint is based off of the recommendations and treatments from the 2017 updated guideline by the American Academy of Otolaryngology. And we're going to focus more on posterior and horizontal canal because those are the most two common. The anterior canal, they don't even talk about because it's so rare. Okay, so first, why are we the optimal healthcare professionals to treat BPPV? So we're able to evaluate and treat any concurrent gait and balance deficits. We can address any functional changes in bed mobility, transfers, and ambulation that's related to BPPV. We spend a lot more time with patients, so we're really in that best position to identify any undiagnosed BPPV. We're able to schedule patients quickly and at a frequency that's timely to address their BPPV, and we can address any residual movement sensitivities that are present afterwards. Okay, so after this presentation, I'm hoping you guys will be able to have a better understanding of the pathophysiology of BPPV. I think it really helps to understand what you're seeing and to understand why you're doing those certain positions, and it's also important to educate the patients. We're going to go over how to test for BPPV. We're going to go through the repositioning maneuvers. We'll talk about some differential diagnoses, which really helps in the subjective portion to recognize if it is or is not BPPV. And then we'll be able to give appropriate vestibular exercises. Okay, so BPPV, it stands for benign paroxysmal positional vertigo. So the paroxysmal part is really important. It's sudden and short. So if you're hearing things like the room is spinning for hours, it may not be BPPV. So that's an important part of the subjective. Positional, it's always triggered by certain head movements or changes in positions. And then vertigo means a feeling like the room is spinning or you're spinning. So just a refresher of the vestibular ocular reflex. So activation of the VOR system causes eye movement. So the goal is for it to stabilize images on the retina when your head is moving. So kind of like the VOR ×1 exercises, when my head goes right, my eyes go left so that I can still see my finger, and then opposite. So that's the function of the VOR system. So if the system is impaired, that's when you have vestibular nystagmus. Okay, so here's just a look at the position of the vestibular system. You can see that the posterior canal sits about 20 degrees below horizontal. The anterior sits at almost in a vertical position, 70% with respect to the horizontal, and that's why it's so rare for the debris to get stuck in the anterior canal, and it's so easy for it to fall into the posterior canal. The horizontal canal is about 20 to 30 degrees, the naso-occipital angle, and so that's the second most common canal for things to get stuck in. If you look here, each of those canals has an ampullary segment. In that ampullary segment is the cupula with the hair cells that deflect. So depending on how your head is positioned, the endolymph will flow and it'll either excite or inhibit the response, depending on how the cupula is going to deflect. So for the anterior and posterior canals, deflection away from the cupula is exciting. Deflection towards the cupula inhibits the nerve. The lateral canals is opposite. So for lateral canals, deflection of the cupula towards the ampulla excites and away inhibits. This is the one to remember because it gets really complicated when you're testing for horizontal canal. So just remember that one. For horizontal canal, towards excites, away inhibits. So here's the anatomy of the vestibular system. So here you have the utricle and the saccule. So these are considered the otolith organs. This is where the crystals live. This is the otoconia. These are calcium carbonate crystals. So they're kind of interwoven in a membrane, and you have the hair cells in the utricle and saccule. So these crystals as they move with inertia with the head movement, this is what depolarizes the hair cells. So utricle and saccule, they detect the linear movement, so in a vertical plane or horizontal plane, so it's kind of like running fast or jumping kind of motions. The posterior anterior horizontal canal, they detect rotational movements, so movements of the head more. So the difference is that the utricle and saccule use these crystals to detect movement. In the canals, it's only endolymph, so there should be no crystals in there. So Bppv occurs when the crystals dislodge from the utricle and saccule, and they start to float into the canals. Okay, so nystagmus, understanding what you're seeing when you're seeing nystagmus. So for the anterior canal, it influences the superior rectus. When you see nystagmus, the beats that you're seeing is the corrective saccades. So if you're, for example, positive for right anterior canal, the superior rectus is going to want to activate and pull the eye upward. So the reason for anterior canal you see downbeating nystagmus is because that's the corrective saccade trying to correct that pull from the superior rectus. For the posterior canals, it influences the superior oblique. So you see how it wants to turn inward. So this is a right eye. So the corrective saccade pulls it back outward. And that's why you see the torsional kind of upbeating nystagmus when you test for it. And then for the horizontal canals, it influences the ipsilateral medial rectus, so the eye wants to pull in towards the nose. And that's why when you're testing for it, you'll see a geotropic towards the ground beating nystagmus because it's going lateral to correct. Okay, so just some statistics. There's a lifetime prevalence of 900 per 10,000 people. So that's about 9% of the population. So 2 or 3 of us in here at some point will experience Bppv. Tony's one of them. So 2 more people need to volunteer. It's women over men at almost a 2-to-1 ratio. The posterior canal is the most frequently affected due to that anatomical positioning we talked about. So it's 85 to 95% of the cases. Horizontal is anywhere from 5 to 22% of the cases. And then the anterior canal is anywhere from 2 to 3%. So overall, people over 60 are more at risk. 9% of elderly patients worked up for non-balance related complaints have unrecognized Bppv. It's present in 40% of geriatric patients seen for dizziness. So over our lifetime, the number of otoliths that we have decrease because they demineralize. They're getting dissolved in the endolymph. So the fibers that connect them in that otolithic membrane, they start to weaken, and that's why you're going to see them kind of start to float into the saccule and the utricle. Ideally, the little pieces get dissolved in the endolymph, but sometimes because you have a lot of little pieces floating around, they start to clump together like a little rice ball, and it gets harder to dissolve because now it's a bigger piece. And then if you accidentally move your head the wrong way and it floats into one of the canals, then you have Bppv. So for example, a common trigger for women is going to the hair salon. So if they have a free-floating crystal and then their head is back in that position where they're getting their hair washed for some time, that's how they can sometimes have Bppv after they get their hair done. So there is chances of spontaneous resolution for about 27 to 50% of people, but it takes time. So only 10 to 20% of people with Bppv will be seen by a physician and receive the appropriate repositioning maneuvers. 70% will go on to have MRIs, 45% will have CT scans, and then 53% will be treated with medications. So this tells us that if we improve our ability to detect and treat earlier, we can improve quality of life faster, and we can also save on a lot of medical costs. Okay, so subjective is really important. What you're looking for is room spinning dizziness that's lasting less than a minute or maybe just over a minute, depending on if the crystal is free floating in the canal or if it's stuck on the cupula. 50% of people can also report feelings of imbalance in between those classic episodes. So if you think about it, it's kind of like you're having a unilateral hypofunction, so you're still getting mixed signals even between the room spinning episodes. So you're still feeling like equilibrium is kind of off sometimes, especially when it first happens. So your body is still trying to adjust to it. These are also going to be triggered episodic symptoms versus spontaneous. So for people who are saying, oh, I watch TV or I'm just sitting straight and I start getting the vertigo type of dizziness, that's probably also not BPPV because it's not going to be spontaneous. It has to be triggered with positional changes. So things that you're looking for are people saying like it happens when they're getting into or out of bed. If the posterior canal is involved, it's called top shelf syndrome. So looking up at a top shelf can trigger it. If it's horizontal canal, things like checking the mirror when you're driving or turning your head in a horizontal plane when you're walking, or like putting dishes away in a dishwasher, you're like that pitch forward kind of plane. So I don't think you guys can see it because it's really small, but here's a list of the differential diagnoses. And I like how they separate it. They separate it by autologic disorders, neurologic disorders, and then other entities. So we don't have time to go over all of these, but I think it's important to kind of know a little bit about the presentation for all of them because it'll help you really be able to differentially diagnose during the subjective. And so if it's not BPPV, we can help triage them to the right healthcare practitioner who might be able to still help them. Some of these, there's really nothing much we can do, and it's important to recognize that earlier so that we're not wasting their time and money. Some of them we can still help. So even if it's not BPPV, it still might be like a vestibular hypofunctioning, and we can still work on vestibular rehab. We can work on balance, proprioception, gaze stabilization. That can still help their balance. This is another look at the same list of diagnoses, but I like this one better because here they separate them into acute vestibular, triggered episodic, spontaneous episodic, and chronic vestibular. So here you can kind of, during subjective, you can tease it out better which one it is. So if it's something that's chronic, I might be looking on this side to see what it could be. If it's something acute, I might be looking on that side. So if you guys want a copy of this, I have it at my desk. But so for example, things that I've personally seen in clinic, I've heard people describe like spontaneous episodes of dizziness lasting up to hours with fluctuating hearing loss, tinnitus, and these are ongoing episodes where sometimes they get better, completely goes away, and then it happens again. So when I hear something like that, I know it's not BPPV right away because it's not short, sudden, it's not triggered, episodic. So I'm thinking something more like Meniere's. That sounds, and of course we can't diagnose, but we can tell them maybe go back to their doctors. And something like Meniere's is difficult for us to treat because in between the episodes, they're really fine. They don't have, a lot of issues. If someone tells you the same type of symptom, but it was maybe an acute episode in the beginning, and then it never happened again, and they're slowly getting better, then I'm looking more at the acute diagnoses, and I'm thinking, okay, maybe vestibular neuritis or labyrinthitis, which is swelling of the vestibular cochlear nerve. So that can be due to like a viral infection or something. And so for those people, I might be doing vestibular rehab because it can get better and we can help speed up the process of the vestibular system getting stronger. Ototoxicity, that's another thing to look out for. So patients that are on cancer medications, loop diuretics, antibiotics, like vancomycin, those are very strong and they can cause temporary or permanent damage to the hair cells or the vestibular cochlear nerve. And so for those people, if it's like a permanent damage, then you really want to focus on gaze stabilization and proprioception for their balance. So if we look under the triggered episodic ones, you have BPPV, postural hypotension, perilymph fistula, superior canal dehiscence, vertebrobasilar insufficiency, and then central causes. So these are helpful to tease out because if you know that it's a triggered episodic, but you know also that it's not BPPV, then you can kind of look, okay, what else could it be? You can check to see if it's postural hypotension. So for perilymph fistula and superior canal dehiscence, that's going to be more pressure triggered. So it's not necessarily changes in the head position. For that, it's like the temporal bones are kind of coming apart. So for those, like the Valsalva maneuver every time can trigger it, or really loud sounds and music. And then central, what you're looking for is downbeating nystagmus. And people with nystagmus, because of central issues, are going to have a really hard time gaze stabilizing. So you always want to check smooth pursuit, and if they're having difficulty with that, then you might be leaning towards more central and not Bppv. Okay, so the idea of the canalithiasis versus cupulolithiasis, yes? Oh.
How do you determine if it's acute versus chronic?
So chronic, I think you just have to see over time if it continues to happen. Like Meniere's, they can have it for months, or they'll say it's been happening for 6 months where it comes and goes, comes and goes. Acute, maybe they've only had one episode and they haven't had it again since, but they just feel like imbalanced. So that at that point you're not sure if it's going to come back, if it's something like Meniere's, but if it's just one time they feel imbalanced but they're getting better and it hasn't happened again after quite some time, then you might think more an acute viral attack.
Is there like a number? Like, for example, if it happens more than 3 or 4 times, then it's become more chronic?
No, not really. But, did I answer it? Yeah, I think just time, and then subjective, and having them come back a couple times.
Is there a specific time frame? Like, I've heard anything where acute is from, at one time it was 6 months, then it became 90 days, now it's down to 30 days.
Oh, like until the next issue, until the next recurrence? I'm not sure. That would be a good thing to look into. I'll look into that, but I'm not sure. Okay, so for canalithiasis versus cupulolithiasis, canalithiasis just means that the debris is floating in the long arm of the semicircular canal. Usually the nystagmus will be less than 60 seconds. For cupulolithiasis, it means it's stuck to the cupula, and the nystagmus is going to be greater than 60 seconds. This one is less common and more difficult to treat. So for the stuck ones, you would use either liberating maneuvers, or you can use vibrating tools to try to free the debris from the cupula. Yes, and that's what gives them that room spinning dizziness. So they'll feel their eyes are like beating, and the room will look like it's spinning. And so I always ask, what kind of dizziness? Because they come in, they say, oh, I have dizziness. And I always need to clarify, what kind of dizziness? Is it lightheadedness? Does it feel like just you're imbalanced? Or do you see something like the room is spinning? And that's what I'm looking for.
A child spins around and then stops, that creates a nystagmus too, right?
Yeah, in a way, yes, because their eyes are, not able to stabilize right away.
But I'm guessing based on what you said that's what does this thing.
Yes. Yep. I've heard on the mastoid. I've never actually used it, but I've heard that. Yeah. But luckily, it's so rare. I've never seen a stuck case, so hopefully you don't need to use it. But the mastoid, if it does. So here's just an example of the free floating versus the cupula, so that you understand what's happening. So picture A is the free floating. So you see with the position change, the gravity is pulling the debris down, and then the inertia is moving that endolymph, and it's deflecting the cupula towards the ampulla, and that's what's causing the nystagmus. For the stuck one, you can see the debris is actually stuck on the cupula itself. And so when you turn and the gravity pulls on it, it deflects the cupula because it weighs down the cupula. So it just makes the cupula heavier. And that's why if it is stuck, you'll see the nystagmus right away, because it'll deflect the cupula right away because of the weight. Whereas if it's free floating, sometimes you'll have a bit of a delay. And so that's why they tell you to hold that position for maybe 30 to 45 seconds to see if you get a delayed reaction, because it takes time for the debris to move and for the inertia to activate the cupula. Okay, so for the posterior canal, you're doing the Dix-Hallpike test, and you're going to see that torsional upbeating nystagmus towards the affected side. For the horizontal canal, you're doing the roll test. And so what you're looking for is if it's beating towards the ground or if it's beating up away from the ground. This is actually what's going to tell you if it's stuck or if it's free floating. So it's a little bit confusing, but so So if you picture your horizontal canal, if I'm testing and let's say I'm positive on the right and I'm rolling this way, so as I'm coming down, if this side is positive, the pull is going to be the medial direction, right? And so the corrective saccade is the lateral, and that's why it's going to beat towards the ground. But here's the tricky part. So if you then test the non-affected side, because excitatory always outweighs or beats the inhibitory stimulus. So even though the debris is on this side, because this one is excited and this one is inhibited, you might still see a very mild nystagmus on this side. So horizontal is tricky because you're testing both at the same time, whereas posterior, it's like you're doing posterior anterior, you're not exciting both posteriors at the same time. So you're not getting that confusion. So ideally you're looking for a very intense geotropic towards the ground beating on the positive side and either none or a less intense on the unaffected side. So it can be kind of tricky because sometimes you can't really tell which one is more intense, which one's less intense. So you can either just treat both sides and then retest and hope it's gone, or you can cross-corroborate with the bow and lean test. So if you use the initial roll test just to figure out which, if it's stuck or if it's free-floating, so less than 60 seconds, geotropic beating, you know that it's free-floating. And that's the one you're going to see most common anyway, so we'll talk more about that one. But then you want to cross-corroborate with the bow and lean test to figure out which side it is. Let's say you can't figure out which side it is and you want to just treat the correct side. So with the bow test, if this is the horizontal canal, the ampullary segment is more in the front. First, you're going to flex your head to about 30 degrees to get it perpendicular to the ground. Then you're going to lean forward so that it's perpendicular to the ground, parallel to the ground, perpendicular to the ground. The debris should float towards the ampulla, exciting it. And so since both are being excited, the more neurally affected ear, the nystagmus will be towards that side. And then if you do the lean test, so here you just want to extend about 60 degrees to get it perpendicular to the ground. Now both signals are inhibiting, and so the one that's inhibiting more will be the more, so then you'll get the nystagmus beating to the opposite side. So you can either do this or you can just treat both sides. So tips for testing, you want a quiet, non-stimulating environment. So a lot of times in the gym, there's a lot going on, there's people, and so patients tend to want to look around, which can be confusing if you're looking for a nystagmus, or they're focused on something, they're gaze stabilizing, which can inhibit the nystagmus. So what you want is to take them to the back room, quiet, non-stimulating. I tell them to just kind of stare off into space and try not to look around. Ideally, if we had Forenso lenses, that might make it easier to not gaze stabilize, but we don't have that. So if you can dim the room, or sometimes if their subjective sounds exactly like Bppv, but I'm not getting a positive, you can even have them just close their eyes and then just go based on a positive subjective that they felt the spinning, because sometimes just even having their eyes open can cause them to gaze stabilize and then you won't see it. You want to make sure they're not on any medication to inhibit vertigo. So like meclizine is a common one that they take. If they're on it, then you also might not see the response. Okay, so we'll go through the Dix-Hallpike testing into the Epley's repositioning maneuver. And what I like to explain to the patients is that it's like that little kid's maze game where you're trying to move that little ball through a maze and have it land in the center. And that's what I explain. That's what I'm doing to their head to try to move the debris back to the center. So I have Alyssa who's going to volunteer. So I always test the non-affected side first for the posterior, and then I'll test the side that the patient thinks it is. So what I like to do is I like to take a pillowcase and I'll go from the hip to the shoulder, and then I'll lay it back to make sure their head's going to clear. So I might have you scoot back just a little bit more. Okay, so let's say I already tested the affected side or the non-affected side and it was negative. So then I'll have her test the affected side, and I'll usually demonstrate the positions that I'm going to have them in beforehand so they know what to expect, so that when I guide them through it later, they know what to do. So I like to block here with my elbow to give them some support because a lot of times these are our more elderly patients, and so having them come down really quick unsupported can feel really uncomfortable. Okay, so I'm going to turn her head 45 degrees and then 30 degrees extension, and then go ahead and hold on to my arm. Okay, on the count of 3, we're going to come back. 1, 2, 3, back. And then here is where I'll just kind of hold her head. I'll push it in a little bit so it's not so uncomfortable and just hanging. And so I'm looking for that nystagmus, and let's say I see it. So then I'll wait for about 60 seconds. So studies have shown that the longer you wait, the more likely that you'll get all the debris out on the first time. So you don't have to do it twice. So let's say I wait anywhere from 60 to 90 seconds. So the next position is I'm going to have her turn her head 90 degrees. So on the count of 3, we're going to go 90 degrees. 1, 2, 3. And here you'll see another nystagmus response. And then I hold it here for anywhere from 60 to 90 seconds. And then Alyssa, I'm going to have you bend your knees up. Okay, so I'm going to have you roll onto your left side, and then you're going to be looking straight down at the floor. On the count of 3, 1, 2, 3. So my hand is always on her head to make sure that I'm controlling it, because if she comes out of it, then it's not a clean maneuver, and we probably have to redo it. So 60 to 90 seconds, and then Alyssa, I'm going to have you kick your feet off the table. And then on the count of 3, we're going to sit up. 1, 2, 3. I'll help her up. And then I always make sure I'm right in front, so I'm still guarding my patient in case she's dizzy or she's going to fall. So that's for the posterior canal. And then, so let's say it is stuck. The maneuver you would do, it's called the Semont liberating maneuver. So let's say it's the right posterior. So I'll turn her head 45 degrees. So it's always posterior, anterior, right? So we want to start with the affected side down first. So this is the one where I'm going to keep your head this way. And then it's got to be fast because it's a liberating maneuver. So it's all about the speed to try to shake it loose. So on the count of 3, we're just going to come down. Okay, keep your head this way. Okay, 1, 2, 3, come down. Yep. And so you make sure it's that posterior angle is down. You have them here for about 1 minute. And then on the count of 3, you got to whip across really fast. So this is harder for elderly patients. So you might want to try the vibrating tool. But if it's someone who's younger who you think can handle it, then you can try this for the liberating. So on the count of 3, we're going to move again. 1, 2, 3. Yeah, so this one, her head has to be like this. So this one, you might have to hold their head a little bit better. But you do that several times, and then you can retest the Dix again to see if it's now free-floating or maybe it's gone. So that's that. And then go ahead and lay back this way.
Terrible.
Yeah, ideally it's a little fast because sometimes it's that inertia, that movement that helps to move everything. Okay, so they said for the, so that's the Semont liberating maneuver. So this is the roll test we're going to go through. So for the roll test, the clearing maneuver, they said to do either the 270 or the 360 degree barbecue roll. I've seen studies that said the 270 might be better, but again, because a lot of our patients are older, it's a little bit more confusing for them to step off halfway through. So it might be easier to just do the whole 360, but I'll demonstrate both. Okay, so for the roll test, because you're trying to get that horizontal canal perpendicular or level, so you're going to have them in 30 degrees of flexion. So try to do the unaffected side first. So let's say it's the right horizontal. You go left, and you're looking for hopefully no nystagmus or very light nystagmus.
Again, you're asking them to focus on anything or not?
No, I'm asking them to stare off into space, but try to keep your eyes in one direction and not focus on anything. Okay, so let's say I see either no response or a little bit of a very light nystagmus, and then I'll bring them back to neutral, and then I'll check the other side, and then hopefully it'll just be really intense so I'll know, and I don't have to do the bow and lean test. So if it's positive on the right side, you want to start rolling in the opposite direction. So I would roll this way to clear. So this is the beginning of the barbecue roll. So from here, I'm going to have her turn onto her stomach, and my cue is going to be look down at your belly button the whole time so that she keeps a little bit of that cervical flexion. Yeah, so it depends on your patient. It might be a little bit harder. So go ahead, I'm going to have you roll onto your stomach, and you're going to kind of put your head down into your hands. And I'm going to keep guiding her head to make sure she doesn't look up. Good. So if I'm doing the 270 degrees, this is the point, probably not on this table, but I would lower the table, and then I would have her come up into quadruped. So still looking down. And then I would have her step off. So if it was the right side, I'm going to have her step off with the right leg, but don't do it because you're too high. And then from there, she would just sit up and whip around. Because at this point, technically, with that turn already, the debris is supposed to be evacuated from the canal. So she doesn't have to do the full turn. So if you can get back on your stomach. So that's how you would do the 270. But for the 360, then I'm just going to have you turn onto your side. And all of these are holding for 60 to 90. Yep. So this one's just more gentle for our elderly patients, and then she can sit up after that.
What about your elderly patients with like cervical stenosis, where they don't have a lot of mobility to be able to do that?
Yeah, that might be harder. And so you're always going to check their range of motion beforehand, just like you're going to do VBI testing. If they're having a hard time with that, you might just have them position their body so that the head turns are still hitting those positions. You just have to improvise a little bit, because if they're able to move it enough to trigger it, then hopefully we should still be able to get them to move enough to clear it. Yeah. So objective tests, like we just talked about, you want to clear the cervical spine, check their range of motion, check VBI testing. You always want to do smooth pursuit to rule out any central causes. You can do the head impulse test. That's the one where you tell them, keep your eyes on my nose. You're shaking their head, and then you go to one side. So you're looking for those corrective saccades. You can do the head shake test, which is the one where you put the Frenzel lenses on and you're doing the same thing. You're just shaking their head, and you're going to see if it induces any nystagmus. So positives for any of those are going to be saccades or corrective saccades or nystagmus. And it'll just indicate that there's some sort of deficit of the vestibular system. And then you can do the dynamic visual acuity test. So that's the one where you have the Snellen chart, and you see what's the smallest line they can read, and then you have them shake their head, and you see, how many lines they lose. So if they lose anywhere from 2 to 3 lines, then usually it's like a unilateral hypofunction. If they lose 6 to 8 lines, then it's a bilateral hypofunction. So you can really work on like VOR training and exercises to help them build that back up. And then you can do the modified sit-sib. So that's the one where condition 1 is stable surface, eyes open. Condition 2 is stable surface, eyes closed. 3 is like on an Eric's, eyes open. And then the last condition is the one that really tests the vestibular functioning, because then it's on the Eric's but eyes closed. So you're taking out vision, you're making proprioception harder, and so it's really challenging their vestibular system. And then treatments, you can do VOR1, VOR2, that's the one where you're having 2 things move. You can do gait with head turns. And then for VOR exercises, you can have them start with sitting, standing, tandem, on a foam, just to progress it. You can have a colorful background going on too, just to make it even more difficult. And then you can also have them work on the modified sit-sib, the condition 4. And that's it. Any questions? We get a good amount of vestibular patients, yeah. And it's good for OT too, because you guys talk to your patients all the time. If they complain of dizziness, you can kind of screen them now and send them our way. All right, that's it.